Welcome back, everybody. I hope you all had a great break. We're heading into the final portion of the meeting, and I hope you're all enjoying the lounges and the exhibits and the photo booth. There's so much fun things to do. So now I'm really pleased to welcome back a previous presenter to one of our Soft Bones meetings, Dr. Rini Pierpont. She's an assistant professor at the Department of Pediatrics at the University of Minnesota. In her research program, Dr. Pierpont investigates the impact of rare diseases and clinical treatment on neurocognitive and behavioral function. Her studies focus on chronic conditions, including pediatric hypophosphatasia. And in addition to her research, Dr. Pierpont is passionate about partnering with patient communities to better develop guidelines and avenues of care for children with rare disease. So Dr. Pierpont, it's so great to see you again, and we're so excited. For those of you who don't know, a couple years ago when Dr. Pierpont started her study, she came to Soft Bones and we went through the CORDS registry to find patients to be able to participate in this research program. And I know a lot of you who participated are very excited to hear about the results and the outcomes. So Dr. Pierpont, I'll give it over to you. Thank you again for joining us.
Thank you so much for having me. I'm really thrilled to be here to speak with you today about one of the components of HPP that many of you in the Soft Bones community have been wondering about and asking about, but has not been well understood. And that is the impact of HPP on social, emotional, and behavioral health. I think we can all agree that everyone experiences HPP differently. For some individuals and families, the physical manifestations are of principal importance, standing in the foreground. These are symptoms that we heard a lot about today, things like premature tooth loss, fractures, rickets, difficulty walking or running, or physical pain. And these issues are life impacting, and for many are the primary focus of evaluation and treatment. But HPP presents with a range of severity and a range of symptoms. This is that spectrum that Dr. Rush talked about earlier today. And for some of you, the physical burden of HPP may be less prominent, yet you experience that HPP impacts you or your child in other ways that are more hidden. Perhaps you feel HPP affects your sleep, your alertness, your concentration, or your mood. Some people have described experiencing brain fog, a sense that your thinking or your memory isn't as sharp as you'd like it to be, or that thinking is more effortful. And today I'm going to share with you the results of our behavioral health research study that my team at the University of Minnesota and I conducted with your participation to study the behavioral impact of HPP. This work was funded by an investigator-initiated grant from Alexion Pharmaceuticals, and my team also received support through the University of Minnesota Clinical and Translational Science Institute. My research group at the University of Minnesota investigates a variety of neurodevelopmental and neurodegenerative conditions, and I'm especially interested in rare so-called orphan diseases that have a neurological component. A couple of years ago, my colleague, Dr. Kiki Sarafoglou in endocrinology, referred several of her patients with HPP to my clinic because she was concerned about developmental or behavioral issues. In addition to research, I also conduct clinical neuropsychological evaluations at our pediatric neuropsychology clinic. And I was struck after meeting a few children with HPP and learning about some of the cognitive and emotional challenges that they were having. And I like to acknowledge this is really what inspires us researchers. And I want to first, mention that the concerns that you express and your questions, that's what drives us to search harder for answers to those questions. And ultimately to be able to provide better care for your families. And this, I think, was really clearly reflected in Dr. Dorn's presentation and her desire to help illuminate a better understanding of neuropathies in HPP. So I really encourage you to reach out to her, to contribute to her studies and help her learn more, and to participate in the registry. So when I was working with these families, I learned that there's very little research available regarding cognitive or mental health manifestations of this chronic disease, HPP, especially in children. Yet I was seeing clinically that HPP was associated with a variety of neuropsychological presentations, ranging from few or no areas of cognitive or behavioral difficulty to pretty significant neurodevelopmental or psychiatric impairment. And this made me very curious. I also learned that there were data suggesting a high prevalence of anxiety and depression among individuals with HPP that was mentioned earlier. But the spectrum of behavioral health challenges, including the frequency, the type, and the severity among children diagnosed with various forms of HPP, had not been adequately described. And we felt this lack of information limited the ability of practitioners like myself and my colleagues to effectively address behavioral health concerns and for the community, for you to understand HPP better. So we decided to conduct a survey focused on this topic. So I'm going to share with you some of the results of the study, and I plan to speak to aspects that will be helpful for a variety of stakeholders in the HPP community. So I'll speak about what we learned about the patients with HPP, but since our research focused on children and adolescents, some of my talk will be targeted to caregivers and clinicians that are providing care for affected children. These individuals also played a key role in the data that we collected. So in this study, we collected medical records from clinicians. This helped us to verify the eligibility of patients in the study and also to understand their clinical presentation better. So I hope the results of the study will in turn provide some information that can be useful for clinicians treating individuals with HPP to give providers ideas about what symptoms to look for. The caregivers, parents of children with HPP, provided the bulk of the data in this study. In addition to older children and adolescents, we wanted to enroll younger children, preschool and school-age children, to include the most individuals possible. We also needed to collect the data remotely to reach many of the families, even before the pandemic, since our group was so widespread. And since a lot of children can't read yet, we primarily collected data about parent observations of their children. So I expect that some of you caregivers will be interested to hear about what we found with the data that you provided. And ultimately, the results of this study will illuminate and center the experience of the patients, the children with HPP, so that we can better understand their condition and its potential consequences. The study we conducted was designed to answer two main research questions. First, do we find a higher than expected rate of behavioral health concerns in children with HPP? And if so, what does that look like? Second, how are these challenges associated with patient characteristics and other aspects of the disease? How are these things interrelated? I'm going to break down what we found by going through several different aspects of behavioral health: sleep, pain, emotions, behavior, quality of life, individually. And the main thing to know is that there was no area that impacted all children. There was no universal finding. And this confirms what we already know about HPP, which is that these symptoms exist on a spectrum. But before I get into those details, I'm going to tell you a little bit about the methods of the study. We recruited 30 parents of children with HPP for this study, and children that we were learning about ranged in age from 3 to 16. The average age of the participants was around 8 years. And we had a fairly even split between males and females. So we had 14 females and 16 males in the study. And we started enrollment at the Soft Bones meeting in 2018, as was mentioned. So that's where we kicked off the study. And we also recruited families through our University of Minnesota clinic, through the CORDS patient registry, which was a very helpful way of reaching a large number of families, and through study flyers that were distributed online by patient advocacy groups, including Soft Bones. And we didn't target any particular patients. We asked families to participate whether or not their children had behavioral health concerns. So children with or without these concerns were eligible. We had 6 participants that we weren't able to analyze data who either had a history of premature birth or a co-occurring genetic or neurological condition alongside HPP, because we wanted to make sure that our sample was really reflecting generally the impact of HPP on behavioral health and not other possible comorbidities or conditions that are known to be associated with neurodevelopmental and behavioral health consequences. And we saw quite a range of physical symptoms in this group that ranged from, primarily the premature tooth loss, the sort of what's often termed odontohypophosphatasia, to quite a range of symptoms, including bone fractures, rickets, impaired mobility, and more kind of severe presentations. So we had this spectrum. 15 patients in the study required treatment with enzyme replacement therapy. So they tended to have a more severe clinical presentation that led them to seek and require that treatment. In those 15 patients, the duration of therapy ranged from less than 1 year on therapy to more than 8 years. So this is what's called an observational study. So we weren't able to, of course, control the length of time on study or to test patients before and after treatment to assess treatment response. So we simply have a snapshot of how they were doing at different time points. Some were on enzyme replacement therapy and the other 50% were not. And those ones tended to have milder symptoms. As you know, HPP is caused by pathogenic variants in the ALPL gene, as was described by Dr. Rush. And we were able to review molecular genetic testing records to verify the diagnosis of HPP in most of the patients. Most of them had a confirmed disease-causing ALPL variant, although in a few patients, we confirmed eligibility using biochemical test results and combined with the presence of clinical features of HPP to help verify when molecular genetic testing results weren't available. Data collection occurred in two formats. So first, we requested that families provide authorization to release those relevant medical records that we use to confirm the diagnosis and understand more about clinical features of HPP, and to identify whether patients had already received documented mental health diagnoses in their medical history. So we collected data on previous mental health diagnoses from a medical professional, things like learning disabilities, mood or anxiety disorders, autism spectrum disorder, those types of diagnoses. And then second, we, as you know, we asked you lots of questions. So we asked caregivers a ton of questions about their children and their observations of their child's behaviors using validated caregiver report measures that allow us to understand how a patient's functioning compares to other children their same age. We looked across a bunch of different domains, including social and emotional functioning. We studied adaptive functioning, so that's a child's independence that's related to things like communication and daily living skills and socialization skills. How independent are they in functioning in those areas in daily life? We looked at their sleep habits. We looked at pain. We didn't study the subjective experience of pain. This was discussed in the pain talk earlier, but we looked at how much pain interfered in daily life. So how much pain interferes with academic and social life and ability to participate in activities. There's questions about that. And then we also ask questions about quality of life and well-being. In going through these results, I'll start out with a high-level overview, and then I'll go through a few of the individual areas of behavioral health in a bit more detail. So I mentioned this before, but there was no area of behavioral health that was a concern for all of the participants in the study. So importantly, 1 out of 3 participants were rated as not having difficulties with any of the aspects of development, behavioral, or emotional functioning that we looked at. These children had age-appropriate adaptive skills, ability to function independently in daily life, and a similar level of ability to other children their same age. They were reported as being well-adjusted and having good quality of life. So just as there can be children with milder physical presentations of HPP, there can also be children whose overall development and behavior are unaffected. But if 1/3 of the participants were unaffected in terms of behavioral health, that means that 2/3 of the children in the study were rated as experiencing at least one significant behavioral health challenge. And about half of our participants had concerns that spanned several aspects of emotional or behavioral functioning and were really impactful for them and affected their quality of life. 30% of the children in the study had an established mental health diagnosis, and several had multiple diagnoses. These included depression, attention deficit hyperactivity disorder, autism, learning disability, and dyslexia. And a few with aggressive or challenging conduct and behavioral problems. And this is a pretty small sample, so it's hard to know if those rates are higher than expected because they either had the diagnosis or they didn't. Because just having 1 or 2 patients with a mental health diagnosis could have a big impact on the percentage in this group of 30 patients. However, we can look individually at the presentation of symptoms using more specific measures, and that's what we did. So I'll break this down a bit now and talk about the areas that were most interesting or surprising to us. One of the most common concerns identified in the study was in the realm of sleep. We studied sleep using a measure called the Children's Sleep Habits Questionnaire, and that measures concerns about sleep onset, about the duration of sleep, about things like, is the child resistant to going to bed? Do they have anxiety around sleep? Do they wake up a lot at night? Do they seem fatigued or sleepy or tired during the day? So those were different areas of sleep that were assessed by this questionnaire. Now, sleep problems in children are notoriously challenging for families to manage. There are gazillions of books on this topic. So even though these difficulties with sleep are pretty common in the general population, the rate of sleep disturbance in the children we studied was notably higher than expected compared to other school-age children. So the rate of children classified as poor sleepers was 57% in our group as compared to 23% of healthy children. So more than double. We found that older children and adolescents were more likely to have sleep difficulties than younger children. They have more difficulties with their sleep duration and daytime sleepiness compared to other children their same age. "29% of children in this study were rated as having significant interference of pain in their typical daily activities. These were questions such as, it was hard for my child to have fun when she had pain. And these questions were rated on a scale from never to always. So never, sometimes, often, almost always, or always. And parents of children with more severe HPP, not surprisingly, reported that their children had overall greater daily pain interference than children with less severe HPP. Interference of pain in daily life was also associated with age, with older participants being more likely to experience interference of pain in daily life. And that seems to mirror the adult literature a little bit. So we've talked about sleep and we've talked about pain. And when you think about the effects that getting poor sleep or having frequent pain could have on a person's mental functioning, which was touched on during the pain talk today, one domain you might think about is the ability to focus or pay attention. So we looked at that. And what we found was that these skills were notably impacted in a subset of our patients, these skills that reflect symptoms of attention deficit hyperactivity disorder, difficulties concentrating, things like that. So we only looked at school-age children for this ADHD measure because it's a little bit harder to identify these symptoms as atypical or not for their age in preschoolers without having a more extensive behavioral assessment. So the parents of these the parent ratings of school-age children provided some pretty strong evidence that children and adolescents with HPP are at heightened risk for developing symptoms of attention deficit hyperactivity disorder, or ADHD, such as difficulty staying on task, difficulty following directions, interrupting, fidgeting, acting impulsively, and generally struggling to maintain their attention and regulate their behavior. And so if you were a parent that filled out the survey, you might be recognizing yes, these were symptoms that my child experienced. In our study, 50% of the school-age children with HPP met the ADHD diagnostic criteria based on the parent ratings. And that's compared to a rate of only 8.3% of children in the general population samples when they developed this measure. So really quite a much higher rate than expected in this group of children with HPP. Now, I want to make sure to be clear that this was not the rate of diagnosis of ADHD in our participants, but these were children whose parents indicated substantial symptoms of ADHD consistent with diagnostic criteria. Notably, the rate of these elevated symptoms was much more than the rate of diagnosis in this sample. Only 2 of the participants had previously received an ADHD diagnosis, which leaves open the possibility that these symptoms might be under-recognized or under-diagnosed potentially in this group of children in this population. Moving on from attention, I want to talk a little bit about mood and anxiety. So one of the key findings was that parents also rated children with HPP as having more symptoms of irritability and depressed mood, as well as more what's called somatic complaints than healthy children. And somatic complaints are really things like stomach aches, headaches, complaining that they don't feel well. These are kind of physical complaints. And we often see elevated risk for somatic complaints in children with chronic disease. So that's not terribly surprising, but it is notable that that also was accompanied by greater symptoms of depression in the children. And the mood and anxiety disturbance that we saw were moderately associated with those concerns that I talked about earlier with sleep and with pain interference. So there was some greater likelihood of having depressed mood and symptoms of depression in children who also had sleep problems or problems with pain really interfering with their daily activities. There was not a reliable difference in aggressive behaviors or challenging behaviors or in anxiety in this group of children as compared to the general population. But again, we had a fairly small sample. So some of the differences that weren't considered statistically significant could be found in larger samples. So these are often found in large surveys, some of the ones that were presented earlier, where we have 100 or 200 or 300 participants worldwide participating in the study. The symptoms of depression and of ADHD that were observed by parents were also accompanied by reduced everyday life functioning and ability to complete tasks and activities independently. So this graph shows that the patients showing more symptoms of ADHD, those are the patients depicted by the orange, yellow kind of colored dots, and the patients who showed elevated symptoms of depression. So on the left to right scale, scores that were to the right of 60 that were higher and indicated elevated symptoms, those patients tend to score lower on our adaptive function measure. So this suggests that children that had more problems with attention and mood regulation struggled more in areas such as their communication and their social life, really impacting those practical day-to-day skills. The next question we had was whether the behavioral signs that we found were associated with general clinical presentation of HPP. So when looking at behavioral symptoms that would be thought to reflect the severity of physical symptoms, such as pain interference and mobility limitations, there was a pretty clear association with severity of HPP. So the patients with greater HPP symptom burden, those ones who tended to require treatment with enzyme replacement therapy, also experienced more of those symptoms of pain and difficulties walking and things like that, and participating in some daily activities that required physical health. However, other behavioral symptoms that are less directly tied to the physical component, so things like poor sleep and attention problems and emotional difficulties, those symptoms were similar between children with severe and mild, relatively milder HPP presentations. So this finding suggests that physical disease severity may not fully account for those behavioral symptoms of HPP. The behavioral symptoms do, however, show significant associations with quality of life. So this chart just shows the interrelatedness of different variables in our study, with blue values showing positive associations and red values showing negative associations. So a negative association means a higher score on one scale is associated with a lower score on another scale. So we look at relationships between anxiety and depression. There's pretty clear positive associations, blue associations, and these are just correlation values, the statistical correlation values. Between anxiety and depression, we know that individuals who are more prone to anxiety tend to be more prone to depression. That's not terribly surprising, but we did see that in our sample, that many of these domains, more sleep problems, more pain interference, more anxiety, depression, behavioral regulation problems, those things were kind of associated with one another. So if you had more symptoms in one area, you're more likely to have more symptoms in another area. But if you look at these associations in red over here with physical and psychosocial quality of life, we find negative correlations with measures of quality, both physical and psychosocial. We found that patients with more problems in the realm of sleep, pain interference, anxiety, depression, aggression, attention problems, hyperactivity, those things tended to score lower on both of these quality of life skills. So this suggests that behavioral health is really meaningful to us, and we should address mental health symptoms seriously if we want to support the whole person. So I want to address this concept that I've heard you talk about, that some patients with HPP report an experience that they describe as brain fog. What is that? The feeling like your brain is slower, or that thoughts come with less clarity, or that there's more mental effort needed for simple tasks. Now, many people experience brain fog even without HPP. So when we haven't slept well, when we're just living through a pandemic, these symptoms tend to be associated with chronic stress and chronic disease, and with overall physical and behavioral health. But I want to talk about some attempts that other studies have made to measure this ill-defined cognitive impairment we call brain fog. So I looked at a study of individuals with a condition called POTS, or postural tachycardia syndrome, which is associated with an abnormal increase in heart rate when standing or sitting. And brain fog is a frequently endorsed concern in this population as well as HPP. So survey individuals with POTS described that the top ranked descriptors of their brain fog were feeling forgetful, cloudy, or having difficulty focusing, thinking, and communicating. And I thought that was really telling, because while we didn't include a measure of brain fog in this survey, our results are pretty consistent with these descriptions. So we found that parents described symptoms of ADHD: difficulty focusing, being forgetful, avoidance of tasks that require a lot of mental effort, or problems with self-regulating. So parents also acknowledged in their responses these experiences of pain, poor sleep, and mood disturbance that their children were experiencing at a higher rate than children without HPP, which can be very distracting and make one feel as if all of their daily activities require more effort and feel less sharp or less efficient. So it makes sense that people with HPP would describe the subjective experience of brain fog if others were observing symptoms that the parents were reported observing in their responses to our survey. So our study was just one step in understanding the impact of pediatric HPP in these behavioral health realms. There are several areas in need of further exploration. So what are some of the gaps remaining? First of all, our study was cross-sectional. That means it was just one snapshot in time of how the participants were functioning at that moment. We would need longitudinal studies to examine whether the symptoms are persistent over time and across different ages. So looking at adults, how does their experience differ, or how is it similar to the children in the study? Would be very interesting to know. It would also be more ideal to obtain information from the patients themselves, since the perspectives of children and adolescents may tell us something that the parent data didn't uncover. And finally, we also weren't able to look at how treatment impacts outcomes. So in this study, medication was prescribed to some patients to ease the clinical burden of HPP in those who had more severe manifestations. But that doesn't tell us how treatment impacts any of these symptoms. So whether a treatment is HPP targeted therapy, like enzyme replacement therapy, or whether it's a more generic treatment for these types of symptoms like psychotherapy or mood targeted medication. So whether, regardless of what type of treatment it is, if the treatment eases pain, if it improves sleep, if it stabilizes mood, if it enables better participation, greater mobility, better independence, those all could be windows into improving behavioral health, because many of these symptoms were interrelated in our research. Okay, I just want to talk for a few more minutes here before kind of opening it up for some questions. So in the last few minutes, I want to talk about what this study implies in terms of connecting families with useful tools and resources. I'll share my perspective as a pediatric neuropsychologist who conducts evaluations to better understand all these different behavioral health domains. So that might be one tool that families could use to gather some helpful information. First of all, not all children will require intensive services or supports for behavioral health. So in terms of recommendations, we can first offer more general support and suggestions to all families, regardless of whether there are areas of concern. So these would be more universal interventions. So first, we can share our knowledge about the effects of HPP on children and families, and arm families with knowledge about areas to monitor, both in the physical and the mental health realm. Some of the supports for pain and sleep were already mentioned earlier by Dr. Sobey, so I won't repeat those here, but they are very important. We can also connect patients with support and with advocacy, we can connect them with other providers such as social workers. So groups like Soft Bones are really essential for helping to allow patients to advocate for themselves and get questions answered and learn about HPP. And third, I'm thinking about my pediatric patients. It's really important to raise awareness about HPP in schools, and find ways that teachers and peers can be part of a child's team of supporters, so that if certain concerns about development behavior arise, teachers will understand that this is a feature of HPP, that this can occur, and that it's a medical condition and not a voluntary or volitional attempt to make problems in the classroom, or to ignore instructions, or things like that. Sometimes these universal interventions won't be enough, and families will develop concerns about behavioral health that need greater attention and intervention, and that's when a child will work with specialists like myself. So in the kind of targeted interventions realm for cognitive and social emotional issues, we have the tool of neuropsychological evaluation. So this is an evaluation that helps to obtain detailed information about strengths and weaknesses, and recommendations for school and treatment specific to the child. Some children can get psychoeducational evaluations in school, but in order to kind of place some of these issues in the context of their medical condition and HPP, sometimes it can be helpful to be evaluated in a medical center. And that's where a neuropsychologist would come into play. Families might consider working with a counselor or a therapist to work on things like behavior management, anxiety, coping, and wellness, overall wellness. And that can be a really great tool. Also, some children might really benefit from training in the area of social skills. So lots of children that have ADHD or anxiety or autism, all diagnoses that we found some participants had in our study, they can sometimes benefit from kind of more direct kind of instruction regarding social skills and how to relate with peers, how to introduce themselves, how to manage some of their behaviors that can interfere with peer relationships. So if kids are pretty impulsive or interrupt a lot or really struggle to kind of inhibit their behaviors, that can sometimes benefit from some awareness and social skills training that can help target those areas. Sometimes ADHD and often other mental health conditions can respond to medication. So families may want to consult with prescribing physicians to consider those avenues. That's one tool in the toolbox that can be considered. And then in the realm of school, there are a number of different types of modifications that can be helpful, ranging from what's called a Section 504 or 504 accommodation plan that formalizes modifications in the classroom, like extended time on testing or extra check-ins with a teacher or a counselor at school, up through special education instruction through an individualized education program or IEP, or a disabilities resources center on college campuses, for example. So there are a number of different levels of intervention and accommodation for schools, and that's another really important avenue to be considering in supporting patients that have the types of symptoms that we uncovered in this work. So I want to go back to this concept I talked about at the beginning about how everyone experiences HPP differently. I think the results of our study really underscore that there's such a diverse range of experiences, and I hope this presentation helped to show that behavioral health experiences fit right among them. And so for patients and families, I really encourage you to listen to yourself and to your symptoms. For those of you who are experiencing behavioral and emotional impact of HPP, or whose children are, I'm here to say that those symptoms are real and they should be addressed just as seriously in your healthcare as any other symptoms. And for those of you who do not experience mental or behavioral health or cognitive symptoms, that's okay too. And you fit right along the spectrum as well. And for any clinicians listening in, I encourage you to really recognize these symptoms and advocate for your patients to undergo screening or more in-depth evaluations that can help your patients navigate behavioral complications of HPP. Follow up on concerns for sleep or mental health and provide referrals. And I think doing so will provide more comprehensive care for patients and hopefully improve well-being. Here is the team that worked with me on this research, and I'm happy to talk through any aspects of this research that you are curious about.
It's fascinating to finally see these results come to fruition, and I think to see some research that actually backs up what many of us parents have seen in our own children. So thank you, Dr. Pierpont. That was excellent. We do have some questions, so I'm going to jump right into some of the Q&A. In light of the study results published on HPP, you mentioned ADHD. Since this is an effect on the brain, could we assume that this is also present in a similar way in adults with HPP?
Yeah, I think that is, again, we didn't, I mentioned the cross-sectional nature of the study, but it does tend to be, so people with ADHD often have persistent symptoms into adulthood. Now, it can be that the symptoms become less apparent or less severe because we kind of learn to accommodate for them. So we may not take a job that requires us to sit and focus on something for hours and hours at a time if this is a concern for us, or we may learn how to, use reminders on our smartphone to not forget things that we are forgetful about. So some of these symptoms, we can learn to kind of overcome them and find avenues where we can build on our strengths. And so it may not be that all patients that had ADHD during childhood will experience them as really severe in adulthood, but they may persist, and they often do persist and are needing to be managed, sometimes with medication and almost always with just kind of accommodations and making our lives fit around how we learn and how we experience the world.
Great. Another question. Does this study include learning disabilities, dyslexia, speech and language disorder? If so, what was the incidence of these impairments in kids with HPP versus the general population?
Yeah, so that's a great question. So we had 2 participants in the study that had learning disability. It was 2. It was a pretty small number. It was around 7 to 10%, I believe, which is not that much higher than the rate of learning disabilities in the general population. Mm-hmm. However, we did not do any direct testing, and it's a little bit harder. Some of the other things we looked at, mood, behavior, ADHD, are often very observational in nature. So parents are very good about being able to determine, does my child have these symptoms or not? When it comes to reading disability, dyslexia, sometimes that requires a more focused, direct evaluation. And so what I would say is it may be that there's a higher rate of those difficulties, but we need to do a study that actually tests those skills in particular, where we have kids sit with us and do our testing and look at their reading and their cognitive abilities and things like that. And then we'd be able to really hone in on whether dyslexia and other learning disabilities are more prevalent in HPP.
Okay. Somebody is just asking a clarification question about what percentage of the children in the study were on therapy.
50% of the children in the study were on therapy.
Okay. Any plans to check back with the families to see if they've progressed any further, or if they've stayed stable or have any new difficulties?
Yeah, I think that would be a really fascinating follow-up study, especially to try to get out, depending on the time frame, some of the adolescents will be entering young adulthood, and it would be really interesting to see whether some of those symptoms are persisting into adulthood. So I think that's something that's worth doing, worth looking at.
Yeah, revisiting. Yeah, that's great. Any evidence that children who may just have one mutation or who are quote unquote carriers may be susceptible to ADHD or any kind of other diagnoses?
So for the most part, to be eligible for this study, the patient had to have a pathogenic variant or to have some clinical symptoms and biochemical symptoms of HPP. So we did not study carriers.
Okay. Another question. Do you have any good articles that we could provide to psychiatrists or therapists that explain some of the B6 issues with HPP? And do you have any suggestions on approaching professionals about this?
So a lot of what's described in the literature, of course, is pretty technical on the kind of how altered levels of vitamin B6 could impact neurotransmitter function, for example, and how that might impact brain development. I don't have any comprehensive resources. I went to the direct literature and tried to really understand what that looked like when starting the study. I think that there really could be some kind of very interesting connections in terms of the neurobiology and the basis of these findings. But I don't have any specific resources to recommend regarding that. I think, talking with some of the genetics experts and really getting their perspective on what might be the most accessible resource would be a good idea.
Okay. Another question. We also hear of some patients with potential diagnosis of autism and HPP, some after they've had surgery for some of the skeletal neurological complications like a Chiari malformation. Sometimes some people have seen reduction in those symptoms. And the person's asking, did you learn anything about HPP and autism specifically?
Yes. So most of the children in the study did not have autism spectrum disorder. There was one patient that had been diagnosed with autism. And we didn't look at it autism specific symptoms, but there were impacts on social skills. There were impacts. So it may be that, that not a lot of children necessarily qualify for a full-fledged diagnosis of autism, so meet diagnostic criteria, but that they may show more kind of subtle symptoms. So they show some of the symptoms, but not all. So maybe there's a lot of social interest, but they may have some awkwardness in social situations, or they may have social skills challenges that are related to some of these other kind of neurodevelopmental components like ADHD. But I do think it would be really interesting to study that kind of subset of kids in more depth and see what those symptoms really look like of ADHD. Of autism.
I agree. Another question. I had heard a couple parents relay experiences about children on enzyme replacement therapy, but when they reduced the dose, or in some cases the child had to come off therapy, some of those behaviors, including ADHD, increased. I'm not sure if you saw anything like that in the study, but this person was asking if you saw any instances of increased behaviors on or off therapy.
Yeah, so there was only one child in the study who had been tapered off therapy. And it had been pretty recent, so it might be kind of difficult to know. Obviously, I don't have data before when they were on therapy, and that study would be really interesting, is to track, if we were able to get assessments on individuals prior to starting and then during therapy, and then if they did discontinue after therapy. But basically the information we have right now is, here are the 15 children who are on therapy, and here are the 15 children who are off therapy, who obviously differed based on their severity of HPP symptoms. So it's not a really well-controlled study, because we're kind of comparing apples to oranges. We're comparing children with a generally more severe presentation who required therapy and different durations of therapy to a group who did not require therapy, who did not start therapy.
Okay. A couple of questions about sleep. Are there things we can do to help our kids get better sleep? Do you suggest that they go into a sleep study? Did you have any kids in the study that had previously had sleep studies? What is your thoughts around additional sleep studies for kids who have a confirmed HPP diagnosis and may have issues sleeping?
I think on a research basis, it would be a good idea.
Mm-hmm.
I can't say as to whether or not there would be findings. I know that we saw the behavioral findings, right? More resistance to going to bed, more difficulties staying asleep, falling asleep at night, which is also really common in kids that have ADHD, some difficulty kind of winding down toward bedtime. Having a really clear sleep routine is, of course, really important. Lots of parents have heard that story over and over, but kind of keeping their kids off the screens and doing more kind of low-key relaxing activities before bed, and having kind of a pretty familiar sequence of events. We do our bath, and then we read our book, and then we lights out, and that sort of thing. So I think those behavioral modifications will address sleep problems for some children. And for others where those behavioral modifications don't seem to be sufficient, it does seem like it would be worthwhile to study this and to see whether there's any findings in sleep studies that help to explain, which, again, this rate of sleep difficulties being elevated is true both in our pediatric and our adult samples of individuals with HPP.
Okay. Another question, is nail biting in 4 to 5-year-olds a sign of anxiety? Excuse me, my son's preschool teacher said my son's been nail biting more than normal and acting nervous when it's loud. I've noticed if he's in front of a lot of people or new people, he bites his nails to the point of bleeding. So is that something that could be potentially related to HPP in terms of some of these behavioral aspects that you saw?
Yes, so nail biting is not always associated with anxiety. Some people do it as a habit, and some people do it primarily in situations when they're very anxious, and that typically can be a sign of anxiety. So if they are showing other diagnostic symptoms of anxiety, like frequent worrying or worry that's really difficult for them to control, or they avoid situations that they're feeling anxious about. So if they're, don't like big groups and they don't really want to join in on an activity because they're afraid, they're feeling anxious about it. Those are the types of symptoms that would have to accompany the nail biting. You'd have to see the nail biting more, and then you could really, use that as a like an understanding of like, this is one of the physical kind of manifestations of anxiety for this child.
Mm-hmm.
And that's a helpful tool. And I definitely think that it's certainly possible that, and wouldn't be surprising that anxiety would be more frequent in HPP and kind of it's certainly not a universal experience, but it's something that we saw quite a bit.
Okay. How about restless leg? Is that something that is also tied into all of these behaviors?
That's a great question. I'm not sure. I think, if we did a sub-study, I think, the main kind of most sort of striking findings to me were in this area of ADHD and this area of sleep, right?
Mm-hmm.
And so if we take, and pain also as well, but there's other ways to study that as well. But if we took a sample and really kind of started to uncover specifically beyond one questionnaire, but really say, okay, should we do sleep studies on some of these patients? Should we look at a variety of different manifestations? So sleepwalking or kind of insomnia, as they're called, restless legs. Those are things that are certainly described, but wasn't a super big focus of this study.
Okay. In theory, are there any factors that may potentially have a modulating effect on behavioral health outcomes, such as early intervention, treatment as early as possible in those areas?
Yes, bingo. That's really one of the reasons we like to do these type of studies that are more observational, is that it helps us avoid the situation where you have a young adult who's really frustrated, they're not doing as well as they want to, and then they get diagnosed with a learning disability that was never identified, and they feel like, oh man, all this time I thought I was dumb, or I thought I thought I didn't understand what was wrong, and
right.
And so we might have avoided a lot of distress and a lot of feeling frustrated with themselves, and maybe some of these anxiety, depression symptoms surrounding having an undiagnosed learning issue. So absolutely early intervention, getting those supports in place, particularly for things like ADHD and autism spectrum disorder, really well established that earlier intervention is better.
Yeah. 2 more questions. One, did you notice a difference in the behavioral issues from the patients who were on therapy versus not on therapy?
Yes. So in the areas that were pretty closely tied to symptom severity, we did notice the patients on therapy had more symptoms. So those were the things like pain and mobility limitations. However, these other symptoms that seem to be more neurodevelopmental in nature, things like ADHD symptoms, mood and anxiety disturbance, sleep issues, those were pretty equivalent in the patients who were receiving therapy and who are not receiving therapy. So that suggests that it's not really all just explained by how severe your symptoms are, your physical symptoms are.
Okay. Final question. Should patients with HPP then make mental health providers a part of their healthcare teams yearly if the patient has any mental health or behavioral health symptoms?
Yeah, I think this really touches on something that was mentioned earlier today in Dr. Rush's talk of this idea of multidisciplinary care.
Mm-hmm.
I think along with, your genetic counselor, your physical therapist, if that's needed, if your endocrinologist, your neurologist, all those specialists, I do think mental health practitioners will be an important part for a subset of individuals as part of your team, definitely.
Yeah, I agree. I think that's a great point, a great way to close out the session and to lead into our next session too. So, Dr. Pierpont, this has been such a pleasure, and it's so rewarding to see the results of your research come to fruition and again validate what many patients have already been feeling, I think, for years, especially parents who've seen some of these behaviors in their children. It's just to actually see the research come out supporting it is really very validating. So thank you so much.
It's really a pleasure to be part of this. And I just really enjoyed the study, and I throw it back to you and say, your participation is what it made it possible, all of you families. And so thank you for.
Yes, big thank you to the families who took the time. And thank you for coming to our meeting when we had it. That was a lot of fun. Hopefully we'll be able to do that again in person very soon.
I hope.
Yeah, fingers crossed.
Directly, right? So.
Yeah, exactly. Well, we were just talking about mental health, and that's a great segue into our next segment. So we're going to exit this window and go back to the agenda and join us for our final closing segment, where we will do some mindfulness and some chair meditation. So we'll see you over there. Thanks again.